Hey, it's Dr. B, your favorite Psych NP. So today, working at an outpatient mental health clinic, I had 14 patients scheduled, with 3 of those being psychiatric evaluations. First patient today was a 17-year-old female with history of schizoaffective depressed type, and she's currently on Risperdal 2 milligrams twice a day, Cogentin 0.5 milligrams 3 times a day, propranolol 10 milligrams 3 times a day, and sertraline 100 milligrams per day. She's actually remarkably stable. She was in the hospital in January, was discharged. I followed up with her in January, February, and today I saw her again, and she was remarkably stable. We made no changes to the medication. She was previously on Abilify, and then she went to the psych hospital in January and she got switched to Risperdal, and she's been doing well. No hallucinations, mood's fine, and she's going to online school. So everything's well, no changes for her. Next patient, 18-year-old female, history of ADHD and generalized anxiety disorder. She's only on Concerta, 54 milligrams. That's the extended release stimulant ADHD medication, and then 5 milligrams of methylphenidate, immediate release in the afternoon. Doing remarkably well. No changes with her at all. Next patient was a 48-year-old psych eval that was admitted to the hospital for a psychotic episode in February, was discharged with Haldol 10 milligrams twice a day, hydroxyzine 50 milligrams twice a day, and trazodone 50 milligrams at bedtime. She was reporting that she was really tired and fatigued most of the day, was stable, hallucinations were gone, moderate anxiety and mild depressive symptoms, low energy, fatigue. So I just completely decided to take her off Haldol, that is a first generation antipsychotic, and I switched her to Risperdal, and I added Lexapro in the morning. So the new dosage of medication is going to be Risperdal 2 milligrams at bedtime, 5 milligrams of Lexapro in the day, and then 50 milligrams of hydroxyzine twice a day as needed. She was agreeable with the plan, and I'm hoping that switching from a first generation to second generation will do 2 things. Improve the sedation and fatigue that she's having during the day, because Risperdal is less strong or less sedative than Haldol. And then also improve benefit with a second generation antipsychotic that has those serotonin benefits, so it will improve affect, mood, depressive symptoms. And I'll follow up with her in 3 to 4 weeks. Next patient was another psych eval, 64-year-old male with history of major depressive disorder in partial remission and generalized anxiety disorder. He's on Prozac 20, Seroquel 50 milligrams twice a day, and Seroquel 400 milligrams at night. Doing excellent. Anxiety's controlled, mood's controlled, and he feels great. There was really no changes. It was a yearly psych eval, so we just continued everything, and I gave him refills for 4 months. Very stable, no side effect. Next patient was another psych eval, 61-year-old female with history of major depressive disorder, recurrent, and generalized anxiety disorder. A lot of that combo today. She's been on sertraline for approximately 4 years. At times, she's been very stable with no issues, but she has intermittent anxiety that comes back. She also has a history of cancer that was treated in 2018, but always a lingering thought in her head. And then she also has chronic rheumatoid arthritis pain. So today I added 20 milligrams of duloxetine. She also said that her sister in Mexico only takes duloxetine. So I'm hoping that the duloxetine added to the sertraline will help with the pain and the mild anxiety. My long-term plan will be to take her off Zoloft and switch her only to duloxetine. Duloxetine is SNRI, so it's going to have a little bit more kick, and really specifically duloxetine helps with chronic pain. So I'm hoping this change will be able to assist her significantly. Next patient, 30-year-old male, history of major depressive disorder, social anxiety, and ADHD. He's currently on citalopram 20 milligrams, hydroxyzine 50 milligrams twice a day, and guanfacine 1 milligram at bedtime. With him, he was stable. There was no changes. He is struggling with school, reports he's getting C's right now as his grade, so I told him to just be consistent with the medication. And also I'm going to be getting him engaged with a little bit more psychotherapy. He's only had 1 appointment since I met him in November, so we need to increase the psychotherapy. So that's my plan for him. Next patient, 13-year-old female, history of autism spectrum disorder level 2, and she's been remarkably stable. She didn't need any medication changes. She's on Abilify 10 milligrams once a day, and that's it. No weight changes, no issues with mood, irritability, and no side effects. People can get a lot of side effects with antipsychotic medications. Abilify, Seroquel, Risperdal, all these medications cause negative abnormal muscle movements, and depending on the dose, it can be overwhelming for the patient, or it can be tolerated. For this patient, they have no symptoms at 10 milligrams of Abilify. Next patient I had was a 9-year-old male with history of ADHD combined type. He's on Adderall 10 milligrams extended release and guanfacine 1 milligram at night. No changes with him, doing well in school, no weight loss, and he is very stable. One thing that we worry with stimulants in kids is weight loss or loss of appetite. So it's something to monitor at every appointment, is checking those weights. Next appointment after that was a 17-year-old male with history of major depressive disorder with psychotic features and anxiety. He's on Prozac 40 milligrams and Seroquel 75 milligrams. So for this appointment today, he was reporting that he's having a little bit more difficulty sleeping and a little bit more irritated. I told him that really doses under 200 milligrams of Seroquel are just for sleep. So we decided to increase the Seroquel to 100, and that should help with sleep, mood, irritability. But mostly we're going to be targeting his sleep. Once you resolve sleep, a lot of issues resolve on their own in the daytime. So that was the only slight adjustment I made for him. Next appointment I had was a 33-year-old female with history of PTSD, ADHD, and depression. And for her, she's taking 300 milligrams of Wellbutrin extended release. She's taking 10 milligrams of Paxil at night and Trazodone 200 and Adderall 10 milligrams extended release in the daytime. She reports she's doing really well. Concentration is good, anxiety is low. She's able to function with her regular life, go out to the store, is able to work. And I had added the Adderall 10 milligrams about 3 months ago, and it has been life-changing for her. She never had a diagnosis of ADHD until she saw me, but just with those 10 milligrams of extended release Adderall, she has had a remarkable change in her life and has been stable and hasn't needed an increase or anything. So yes, you can just take 10 milligrams of extended release Adderall, and that could be the missing link. As always, thank you for watching, thank you for listening. This is a great, rewarding career where you can work from home or work in person, but at the end of the day, you're always going to be able to help people. And sometimes it's with medication, sometimes it's with words, sometimes it's just listening to them and letting people vent. As always, thank you for watching, thank you for listening. Hope you enjoyed, and I'll see you on the next one.